In this presentation, I'll be going over global health and about my research on the diagnosis and monitoring of tuberculosis via machine learning cough analysis. Hello, I'm Chandra Suda, a rising senior from Bentonville High School, located in Bentonville, Arkansas. A bit about me and my interests are that I'm interested in scientific research, specifically in AI and medicine, and this research has been recognized at various science fairs, including the International Science and Engineering Fair. I'm also passionate about cybersecurity and civic engagement, serving in the American Red Cross and the Congressional Youth Cabinet. Also, I founded and am the president of a STEM nonprofit, AI Mate, which focuses on making quality STEM education more accessible. So in this presentation, I'll first touch on global health and what exactly it is. Next, I'll go over the background of tuberculosis and the global health crisis. And then I'll cover my research, finishing off with the significance and future possibilities. So global health and its importance. Global health is defined as the area of study, research, and practice that places a priority on improving health and achieving equity in health for all people. Essentially, it's about providing a healthy future for everyone, regardless of the location, financials, etc. And this ties into my research, which also aspires to make quality healthcare accessible to everyone. So, what is tuberculosis? Tuberculosis, or TB, is a bacterial disease that primarily affects our lungs. It is also the number one infectious cause of mortality. Although COVID-19 was the number one during the pandemic, TB has again risen to the top. Furthermore, it's estimated that 1.8 billion people have latent TB, while 10 million have active TB. Latent TB is where an individual has the TB bacteria, but aren't actively infected. In addition, tuberculosis has caused 1.6 million deaths in 2022. It can be seen that TB is a global health crisis, and one of the primary reasons is the current issue related to diagnosis. Currently, to diagnose an individual, it's expensive in regards to the equipment and personnel. It's also time intensive, which could take between 2 to 8 weeks. Also, it creates an access barrier in rural areas where the majority of deaths occur. In addition, there's also a lack of predictive monitoring and personalized care. For example, the current solution, sputum culture, could take between 2 to 8 weeks, and also there's a difficulty screening in children because children don't produce sputum. My research helps address this. In my research, I developed an early diagnosis and predictive monitoring system for tuberculosis via an AI-based cough analysis. Here's a brief overview of my solution. So essentially, I developed a machine learning model that can detect between TB positive and TB negative individuals from cough audio. And if the patient is positive, then the predictive monitoring system provides a personalized monitoring of their treatment. The diagram on the right showcases the novel inference architecture. So first, the individual's cough would be recorded. That, in combination with the tabular data, which is their demographics like age, past history, etc., will be fed into the ensemble model. The ensemble model consists of the 2D CNN machine learning model and the XGBoost machine learning model. The 2D CNN machine learning model is used for the cough audio, while the XGBoost model is used for the demographic data. That would result in a binary classification of TB positive or negative, and if the individual is positive, it would proceed to predictive monitoring. Here is an overview of my research methodology. To be able to create a machine learning model that can differentiate between TB positive and TB negative, I first had to acquire a large and diverse dataset consisting of 725K cough audio recordings from over 13 countries. The next step is pre-processing. In the pre-processing step, as seen in the diagram over here, is vital to ensure uniformity of the data. The steps include bitrate, time, and audio channel equalization, and also normalization of the dataset. The next step was data augmentation, which includes white noise and impulse room convolution. I factored in white noise to ensure the model is resistant to background noise, and impulse room convolution, which simulates different room echoes. The next step was feature extraction, in which I tested various different features from audio that include MFCCs, Bell spectrograms, and spectral contrast. These audio features provide a visual representation of the data, in which I chose a Bell spectrogram due to its performance. Here's an example of the audio feature represented as an image. The next step was the binary ML classifiers, In this step, after testing various machine learning models, I chose a two-dimensional convolutional neural network. The next process would be predictive monitoring. So if the patient is TB positive, the periodic cough history, which includes the frequency, the confidence, and the timestamp, will be fed into a bidirectional LSTM, which is a long short-term neural network. A LSTM network is optimal in this case due to data being history over time. That, in addition to the doctor's recommended treatment plan, would be factored into the treatment irregularity algorithm that warns the patient and doctor if the difference between the actual and expected is greater than the threshold. I trained the model in Python using PyTorch and also in the NVIDIA GPU, as the data was fairly large, 32 gigabytes. As you can see here on the right, there's also training loss and accuracy curves. And one important step was I split the data into 70% training, 15% validation, and 15% test. The input was the audio sample's null spectrogram, with output being TB positive or negative. The results and analysis. So I set the primary endpoints, or the performance metrics, as specificity, which is a true negative rate, and sensitivity, which is a true positive rate. That is also in conjunction with the World Health Organization's requirement for a community-based triage test, which is a sensitivity greater than 90% and a specificity greater than 70%, in which my model surpassed both of those metrics, resulting in a 94% sensitivity and an 86% specificity. For the predictive monitoring system, I utilized the area under the receiving operator characteristic curve, which provides the true positive rate and false positive rate with a varying degree in the threshold. Furthermore, I performed a stratified 5-fold cross-validation, which ensures that the ratio between TB positive and negative individuals are the same in each fold. So in the conclusion, I would like to discuss the significance and future possibilities of the research. Firstly, the ML model has a high accuracy and accessibility as it was trained on a diverse populations worldwide. It can be easily accessible worldwide through a web app or a mobile app for free. In addition, it's fast and personalized. It can provide a reliable diagnosis in less than 15 seconds and helps prevent TB relapse and drug resistance by ensuring the treatment is accurate. I'm really excited by the results, and future work would be exploring the architecture's adaptability to other cough-based diseases like pertussis, and also the clinical testing of the model across global testing sites. Furthermore, I'm planning to implement a data collection feature in the application to improve model performance. I also have my key references to the right. Thank you for your time and for Global Health Leaders Conference at Johns Hopkins University for this opportunity. And if you have any questions or would like to contact me, feel free to reach out to me at my email address here or connect with me on LinkedIn.